doctor, sleep doctor and pulmonary doctor from Tufts Medical Center, Dr. Aarti Gruber. Good afternoon, doctor.
Good afternoon, Dr. Sokolina. How are you?
So, thank you very much to our audience. If you have trouble sleeping or sleep next to the snoring partner, this interview is for you. We're going to talk about different sleep conditions besides obstructive sleep apnea and find out what's the most effective treatment for them at the present state of science. And if you're a medical professional who, just like us, trying to make our patients to sleep better, please click the like and share button. This way, together, collaborating together, we can find all the missing puzzles and give the best treatment recommendations for our patients. And let me share you the story how we met with Dr. Gruber. We actually met on a conference, Sleep 2024, and I was impressed not only with the level of knowledge, but also with the level of fashion. I'm all into the beauty and aesthetic, and Aarti really represent that. So from that moment, I was charmed. But in addition to my, beauty admiration, Dr. Gruber, she's a medical director of Center for Sleep Medicine. She's a program director for Sleep Medicine Fellowship and sleep attending and intensivist. So it's doing intervention. And yes, intensivist, doing intensive therapy for the patients, to be correct.
ICU.
ICU, right. ICU, when we are patients, so we are in the most vulnerable situation. You help us breathe. And you also have expertise in narcolepsy, in the general pulmonary, adult and pediatric sleep medicine, and also sleep disorder briefing, insomnia, and critical care medicine. But on another note, I want that interview to be kind of a sign of collaboration between dentistry and medicine. And I hope it's going to be example for medical doctors and dentists to find a good match and start communicating more, because this way we can really help patients. So I'm gonna start with the non-specific question. I want to find out why you choose pulmonary from all the specialties in medicine and how it's all come to the point you are right now.
Oh, well, thank you, Dr. Sokolina. So before I even start my story, I think one thing I definitely want to tell you is I love the fact that you and I met at the sleep meeting this year. And the best part of meeting you was that I already, Tufts Medical School and the Tufts Medical Center is very close to Tufts Dental School. So I've already have a very, very good experience working with our sleep dentist at Tufts Dental School. So meeting you was not like, I didn't feel like, oh, wow, this is crazy. But I was so excited that there are so many sleep dentists out there who can help our patients, because dental sleep is just as important for our patients as an option to treat sleep apnea or sleep disorder breathing, as much as other options we present to them. So I'm thankful that we met, and I'm glad we're doing this today. So in terms of how did I get here to doing sleep medicine and all the other things that I do with my life. So when you go into med school, you don't think about what kind of doctor you want to be. You just want to be a doctor because you want to help people. And I did my medical residency, internal medicine residency. And I remember my first, I was an intern. And I remember within the first second month of my residency, I was doing my critical care rotation in the ICU. I still remember the case that intrigued me so much. I saw this really sick patient, of course, in the ICU. We used to do night calls, and I remember how we actually took care of this patient and saved his life. So I remember feeling like, wow, this is so amazing that sickest patients can come into the hospital and we can actually take care of them, and not just take care of them, actually hopefully save lives. And critical care was my first love, I will tell you that. And because I wanted to do critical care, most of the fellowship programs when I applied were pulmonary and critical care. So pulmonary was almost part of becoming a critical care doctor because we do take care of ventilators in the ICU. So being a pulmonologist was very important, learning about lung diseases and learning about how to manage ventilators. And sleep also became sort of on the same path as I was at Tufts Medical Center, where I did my pulmonary critical care fellowship. Sleep is part of our pulmonary critical care division. So it's a division with pulmonary critical care and sleep. So I rotated in sleep medicine as a pulmonary critical care fellow as part of my fellowship program. And I remember in my second year, I was deciding if I want to do a third fellowship. And my options were, or at least I was thinking about, my option one was you do pulmonary critical care, you've already spent enough time doing this, you're done, or you can do more fellowships. I was thinking of doing interventional pulmonary, which is you do a lot of interventions from pulmonary disease perspective. And then I really fell in love with sleep medicine when I was rotating in my sleep rotations with some of my attendings. And I really enjoyed what I was learning during those short month or 2 months that we rotated in the whole 3-year fellowship. And I'm so thankful I did sleep medicine. I feel like people think of sleep medicine, they think of sleep apnea, and that's it. There's so much more to sleep medicine. There's so much in terms of the neurological diseases we deal with, pediatric populations we deal with. So it is so much more than just sleep apnea.
Absolutely. That's what I want to find out. My next question, what we never discuss on our channel, about a lot of patients, I come across. And I love your passionate story, how, from one step, like you learn one thing and really, like, this is really essence of the doctor. Your pathway represents the essence of the doctor. So my question to you about restless leg syndrome. A lot of patients complain on something with the legs during night. Sometimes I have also, my grandma always complained on my legs at night. So tell us, what exactly is restless leg syndrome?
So, as sleep doctors, we do need to know a lot about neurological disorders because we do look at EEGs of the brain. We look at the brain waves of the patients when we're looking at sleep studies in the sleep center. So restless leg syndrome is a neurological disorder that affects patients, like you said, typically when they go to rest. Where when they go to rest, which is typically in the evening when they're ready to hang out, just chill, watch TV, or ready to go to bed, they start feeling this crawly sensation in the legs, typically where they feel, you know, uh, the numbness, tingling may occur in the evenings, especially during restful period. Let's say getting into bed in the evening, and they feel the urge to move their legs, which can make falling asleep very difficult. It is a clinical diagnosis. So, in sleep medicine, we do see those patients with restless leg syndrome, and typically it is a lack of iron in your body or the brain iron is reduced in these patients, which can lead to these restless legs at night. And there are a lot of things we can do for these patients when we see them, so we can talk about that.
What can you do?
So there are several things we can do. There are behavioral modifications. As you know, in sleep medicine, first thing is try behavioral stuff. So reducing caffeine intake, reducing smoking is helpful in these patients. And especially you can apply some non-pharmacological therapies before going to pharmacological treatment options for patients. We, cold compresses or warm compresses may be helpful in the legs. Sometimes we tell, having massages or using some of the compression stockings can be helpful in the evenings for some of these patients. You always have to you as a medical doctor, we always think about other things. Restless leg syndrome could be similar to neuropathy in diabetics. So you have to kind of keep an eye on everything when you look at their medical history, look at their medication lists, and make sure you're not missing something else. So you always have to be cognizant of those things. And obviously there are pharmacological therapies that could be used depending, but the first line therapy or first test I do on all my restless leg patients, or if I'm worried about restless, is checking their iron levels, iron storage, which is ferritin levels, which we do to check how low their iron stores are, especially in women, especially in young women who are menstruating, losing blood every month during periods. So it's that's the big starting point, and then obviously we have to look at other things and then make a treatment decision based on what we find.
Now I ask you about another question, also related to sleep condition, what we don't discuss that often: narcolepsy. What exactly is narcolepsy? We had an interview from the patient standpoint on our channel, which was good. Now I want to see narcolepsy through the eyes of the doctor. What exactly is narcolepsy?
Well, I'm glad you asked because, again, this is another neurological disorder that we see quite a bit in our sleep medicine world. Of course, there are centers who are specialized in narcolepsy. There are doctors who are specialized in narcolepsy, but at Tufts Medical Center, we see all sleep disorders, including patients who have narcolepsy. So again, narcolepsy is another neurological disorder where you have dysregulation of your sleep and wake cycle. So the dysregulation is there because of lack of some of the brain hormones that are supposed to be in our brain that tell our brain when it's time to wake up, when it's time to go to sleep. Those neurotransmitters, what we call these hormones, are lacking in these patients or very reduced in these patients. We don't truly understand why some patients develop narcolepsy. There is a HLA or the DNA molecules that we can check for in these patients to see what are your chances of if patients present with certain symptoms and we're suspecting narcolepsy, we can check the genetic tests, I guess, to put it in a simplest way, to see if they have narcolepsy type 1 versus type 2. So we can do a lumbar puncture to look for these hormones to see what levels they are and define if they have narcolepsy or not. So it's truly a lack of neurotransmitters in the brain that kind of control your wakefulness during the day. And this is because they are in reduced numbers or very low numbers, there is dysregulation of what happens in these patients. So basically imagine there is a super center that controls small stores.
Mm-hmm.
So imagine the Walmart being the big center, and then they controls like every little store on the market. And now this store doesn't have enough supplies to give to all the small stores. So let's say Walmart sends supplies to small, supermarkets near your house or my house. And now supermarket is lacking enough supplies, so it's not going to give it to the other stores. And so that means these small stores are not going to have enough supplies to give out to people.
Yes.
Similarly, where these hormones are, this is like the super center of wakefulness. They're called orexin.
Mm-hmm.
That's reduced in these patients, and that controls a lot of the wakeful neurotransmitters in the rest of the brain that keeps you awake. So it's not a simple system like wake, shut down at night.
Yes.
It's multiple systems in our brain, and orexin molecules kind of control all the wakeful hormones. And so these patients tend to have very high tendency to fall asleep anytime.
Mm-hmm. Anytime.
They can fall asleep quickly. They can get into REM sleep in less than 15 minutes, and that's one of the ways to diagnose these
Yes,
disorders.
yes, yes.
Um, and obviously, we do sleep studies and daytime nap tests for these patients to get a diagnosis. Obviously, clinical history is very important. Whether they are having other nighttime symptoms that give us a little bit more information, whether we should even test for narcolepsy or not. So, patients with narcolepsy may describe hallucinations when they go to sleep. They may even describe having sleep paralysis, they feel paralyzed in sleep. They might and they're very sleepy during this day, so that's like that ominous sign. They will describe excessive daytime sleepiness, and they're sleepy all the time. They can sleep 16 hours, no problem, in 24
Yeah.
hour period, and
This is
still fall
difficult.
asleep. Yeah, it's a very tough disease, but people do fine once they're treated. They can live a normal life. They can um,
Function.
function very well. I have a patient who's a lawyer. She has taken her bar exam and she's doing well in life, but she has narcolepsy. So it is, it it's always harder. Sometimes it gets diagnosed too late. In some patients,
Yes.
and typically it develops in your teen years, into your 20s to 30s, but some patients come to us very, let's say you suffering for
Later.
10, 15 years by the time you see a sleep doctor who is able to recognize it and diagnose it.
That's why we have our program. But people who have similar symptoms, they can find help. So
Yeah.
now I'm going to ask you some hard questions. Even though I'm a dental sleep medicine, so I help people with the different types of oral appliance to make them sleep better. But I still believe in the good qualities or magical power of CPAP machine. And for my patients, for a lot of my patients, I want to make combination therapy, CPAP machine and oral appliance, give them that freedom. So I'm going to ask you the questions about CPAP machine. What the most essential CPAP accessories, what you recommend, what can enhance patient comfort? Because, doctors, the golden standard, they give a CPAP. But when the patient come face to face with the CPAP, then the trouble starts.
Yes. So I think prescribing CPAP is the easiest thing you can do. All you're writing is a prescription. It goes to your DME company, and DME company is like on its own, right?
Yes.
So I think, one of the things I think as a physician I can do is really educate the patient in my clinic when I talk about CPAP. Just having that education of what CPAP is, how it works, how it opens up the airway, how sleep apnea or sleep disorder breathing affects your health. That alone, education, encourages patients to want to use CPAP, in my opinion. That's like my first accessory, I would say, that I use is education. If you can educate your patients on why it's important, there's a high chance your patients are going to be compliant with their therapy, especially when they're brand new to therapy. And having an open door for them to come back to you, to have a portal, say, send me a message on the portal if things are not going well. Early on, within a first month or first few weeks, if you're not doing well, call your DME. If the mask is not working, call your DME like the next day. Don't wait 2 weeks. So some of the things that, even today I had clinic this morning with my fellow, and one of the patients, it's like, we're restarting her on CPAP. She had tried it in the past, didn't like it. So some of the things every patient is going to be different. Their issues are going to be different. Some may say, I have a lot of dry mouth. How do I? So you have to make sure they understand the humidifier, how it works, how you can humidify your environment. So having that is important, because a lot of times we all live in a different household. We may have different heating systems, and how it gets, some houses might be drier than others. So you have to understand their environment they live in. Other sleep accessories I always definitely talk about is the best way to find comfort. I'm all about comfort when it comes to sleep. I imagine if I have to wear a CPAP, I want the most comfortable CPAP, the easiest way to I can handle it, and I want the same for my patients. So some of the other accessories we always talk about is the CPAP liners. So a lot of times there are patients, who start, there are leaks from the mask because it's just not well fitted. I think the masks have changed over the years. The new masks are better. The silicone fitted masks are better, but they can still leave. If you have acne prone skin, it can cause issues. So I always say use liners. They're not covered by insurances typically, so we ask the patient that they'll have to buy it. If I ever have samples in my office, I'm happy to give those out to patients. But typically we do recommend liners. Also, a lot of the new masks have foam on it, so that's important. So again, depending on the patient, you want to make sure the leaks are addressed, because that's what wakes patients up at night, and that's what your patient is not going to be compliant if they're waking up from the CPAP machine.
Of course.
And there are CPAP hoses that exist where they can be cumbersome for some patients to have a hose in your bed. So there are like holders or lifts where you can put the hose on top, and this also allows, so the water doesn't get into the mouth of the patient in the middle of the night. So that also allows for that. There are CPAP pillows that exist on the market. Again, CPAP pillows can also be helpful in how, if the patients can sleep on their side in lateral positions, and which is comfortable for some patients. Not everybody wants to go to sleep on their back the entire night. No one should have to do that. Imagine having back pain. We all change positions all night long, so I can't expect anyone. So a lot of these CPAP pillows can allow you to sleep on your stomach, on your side. So there are, many small tricks, small things out. Depending on the patient needs, you can recommend different things. Of course, not everybody needs everything that I'm talking about. And and then there's another thing that I came across. It's called Tap Pap, which is like a nasal pillows mask, but it kind of keeps the mouth closed. So there's an extension that's added to the mask that it goes right under your lip and kind of keeps the mouth closed. And a lot of patients complain that I don't know how to sleep with my mouth closed, and there's a large leaks from it. They end up waking up with dry mouth. I have a patient who drools a lot at night, so that would be like an option for someone like her. And then there's no straps attached to this mask, so there's a tubing in the back, and it's, a lot of patients will complain. I get headaches with straps that are on. I get, as you guys all, I don't know if you've seen our president Biden.
Yes.
Had straps marks on his face, and everyone asked if he's using CPAP. I actually gave an interview on that last year. So I think you have to find, not everyone's going to need all these things, like I said.
Of course.
So you need to find, that's why, you need to see your patients, follow up, and address these needs early on to hopefully get them compliant with their therapy.
Thank you very much, doctor. We really appreciate all the tips and tricks and advice on important therapy to get you sound night. So thank you very much. We really appreciate your expertise.
Thank you so much, Dr. Sakolina.